Hello, Matthew.
Hi, Robert.
Hey, how are you?
I'm well. Thanks for setting this up.
Good. Yeah, I think you may have actually started the webinar. Let me
Okay,
see if
did I jump
I don't know how to stop. I don't think I can stop it,
the,
which is no big deal, really, because do you have any handouts or anything that you're planning on showing?
no, I sent around the
I think I am. I'm using my computer audio.
island. I can hear you now.
Okay, thank you. Is that Matt?
That is.
Hi, Matt. Well, I'm trying to work on the technology end here.
Okay, you're all set.
Thank you. Is anybody else on the call, Robert?
Yeah, we've got Matt is here, you're here, I'm here, and then we've got 9 attendees so far.
I'm not sure why I can't see that information.
It's there somewhere.
Okay. So are we, is it
Muted.
Yeah. Yeah, I would think so. And yeah, I mean, I think one thing that I was really looking forward to in having actually this journal club was, I think, the perspectives from people who are really, in the field and working in these contexts of how they think that would play out. Would it be feasible? Would it be feasible to implement that nature of assessment?
This is Dennis. That was one of my questions as well, having to do with adding another assessment to patient or to nurses when they are bringing a patient in. I know in my hospital, they have probably a 4 or 5 page assessment, everything from bowel and bladder to, home living, and do they need social work services? We do an audit C, and all of these types of things, and adding another layer on top of that. I mean, I think that this tool would be good. And I think one of the points that you brought out was very important. When you're asking about sedatives or tranquilizers, how many people are going to say, oh yeah, I took an Ativan, as opposed to, well, what do you mean?
Yeah, and so I think that brings up a great point that, perhaps editing or adapting this survey to the population it's under use in. I think just off the top of my head, one thing in particular, I know we see more frequently nowadays a lot of synthetic cannabis use, and that's something that we're not routinely testing for. In fact, it's something that people are using to elude testing. And so maybe the addition of some substances that we're not getting good data on, whereas substances that, I think didn't perform as well on this measure, like the sedatives tranquilizer category, I think are ones that we might think about adapting the wording of, maybe being more precise, giving some examples that are easier for people to relate to. I think that would certainly improve the performance. I think it's also a really great point, and I think that that weighing of survey burden versus clinical usefulness is one that needs to be thought through as well. And I think the advantage of it is it's a brief survey, but even a brief survey in a large stack can have an additional time burden on both patients and staff.
Yeah, the other thing that I thought was interesting in the facility that you used to test, they didn't test for methamphetamines. I mean, that's really high incidence of use, at least now in the southern United States, rural areas, kind of where I live. That to me was a little bit mystifying, why they don't have that as part of their routine drug panels.
Yeah, I very much agree. And I think, historically it's been, I know, unevenly regionally distributed, and New England has seen, I think, a heavier share of opioids relative to methamphetamine, but it is certainly on the rise, no question, particularly in this region. And I think that's a no-brainer one that, I think we probably need to be assessing both fronts.
That would apply also to the fact that this was implemented in an inpatient unit. The kinds of behaviors that you might see with methamphetamine use are kind of likely to draw attention if there's agitation and hostility and violence. And, I would think that at least I'm with Dennis, I'm not as far south as he is, but it started coming across from the west too. So yeah, you both have a point about that.
Yeah, certainly.
There's a lot of noise going on, and I'm trying to figure it out. Is there somebody who's wanting to speak? I don't want to cut somebody off. I'm assuming not. I'm sorry, what were you going to say, Matt?
Oh, yeah, I know. I also heard the ping, so I don't know if someone else was asking a question, but I think maybe to elaborate a little bit on that point, in thinking of that clinical presentation, that we may see more maybe agitation, more aggressiveness in some cases among people who are using methamphetamine. It is possible that, I think this is a biased sample by who we were able to recruit, and bias based on who was maybe more subdued, maybe more approachable. And so, the possibility that Also, this is not representative of some of those types of clinical pictures in the mix.
I just have another question, Matt. I believe what I heard you say, that you were trying to not include people who have psychotic symptoms. Was that part of your criteria, that they would not have psychotic symptoms?
So we saw people who had, I think, lower level, less clinically acute psychotic symptoms. We, in collaboration with nursing staff, we're drawing a threshold around people who were really oriented and able to, consent. That we were, certain that they were understanding fully what the study entailed and able to complete it. So there were some cases where people might not have been oriented and might have been excluded on that basis. There might have been other people who had some degree potentially of auditory hallucinations, some degree of delusional thinking that might have been included.
I'm just thinking back to some of the methamphetamine clients that I've seen on an outpatient, and they have been continuing to have hallucinations. And I was just wondering if that might have been a limiting factor in terms of including them in your study.
Yeah, absolutely. I think, on average, we assess people 4 days after their admission, but that, of course, varied. And so, it could be that we were scooping up some people once they were more clinically stable, and it could be that we were missing some people if the timing hadn't lined up right, and they might have been still experiencing some of the more acute symptoms of the patient.
I have another question. Looking, and I know you're probably trying to assess the tool to be used, but there wasn't any mention of alcohol. I didn't even realize that until I went back and just looked. But there's no mention of alcohol or alcohol use, which is still probably one of the highest abused substances in the United States, at least.
Mm-hmm.
And I didn't know whether that was an intentional oversight to leave off, or, I guess primarily because you're looking at this tool, it didn't get mentioned.
Yeah, I think, certainly actually to your, I think earlier mention, I think the Audit C is a really well-validated instrument that comes to mind as, the thing that would certainly be a no-brainer inclusion in this type of self-report survey. I think that's the one that I would be inclined to go with. We didn't include that, unfortunately, in our study. We were assessing sort of a range of things beyond illicit drug use, but I think that probably actually was a miss in this case. Very good point.
Thank you.
There had been a question, I'm sorry, I had to step out for a minute. There had been a question that I had about the alcohol use also, Dennis. I didn't think that was the chart was correlating with the language. Did you look at that, Matt?
I did actually, and yeah, I wanted to follow up on that because I'm a bit away from the data, but I had gone back and tried to look at that, and I think that actually is a discrepancy. I wasn't able to find a source of that 58% mention in the text, and so I think I unfortunately can't pinpoint where that figure must have come from, but I know that the BAC figure in the table 2 was the one that was representative of the alcohol use data we had. That most people who were evaluated, I think, in a ER setting beforehand would be more likely to have had a BAC administered. And among the people who had one administered, I think we saw it was 23% of the total sample who had a positive BAC at the time of study entry. And of course, that's extremely kind of limited. It doesn't get back to the stretch of the previous 2 weeks in duration. But yeah, I think that was a good pickup, and unfortunately something that I can't speak with certainty to the source of that 58% number, but it looks to be an error.
Great. Okay, thank you.
Yeah.
I also thought your population was fairly on the young side, 36.
Mm-hmm.
I kind of extrapolate that to thinking about how long somebody might have been using in their history. I think Vera, are you wanting to ask a question? I guess not.
Mm-hmm. Yeah, to speak to the age thing that you mentioned, it could be that we were less frequently seeing tox screens administered in older people. I'm not certain. I'd have to go back and look at whether our total sample skewed a little bit older than that. But I think on average we did tend to see a little bit of a younger patient sample.
Yeah, I don't actually have an average age. I haven't got the numbers to support the population that I see. But 36 seems like it's just a little bit younger than my group. Most of the older folks that I see seem to have more of an alcohol substance issue, which goes back to Dennis's point, I think, about the importance of looking at alcohol.
Mm-hmm. Yeah. Yeah, and again, I think I wish we had, I think, better data. And I think that's one of those tricky things to assess on whether maybe older individuals were maybe less inclined to participate. That may have been the case. I couldn't say with certainty.
Oh, I see. Vera is saying she's still muted. Vera, can you speak now? It doesn't look to me like you're muted on our end. I'm getting, Robert, if you're online, can you just see if Vera is somehow muted, because she's sent.
She's showing unmuted. I see her question here, though. I'll just read it out. There are 3 questions. What is the average time for filling out screener? Why include PHQ-9 tool? And what was the most frequent primary diagnosis?
Yeah, so in terms of the first question, for filling out this particular survey, we had a larger survey battery, but this one was probably on average less than a minute. But I think that speaks to the fact that I think the question highlights the fact that we do see, I think, a pretty good range within patient psychiatric treatment setting. There are some people who are going to be certainly more literate than others, more oriented at the time of assessment than others. So the variability is quite large. And I think that also, I think, highlights another thing which is probably worth mentioning, in that we were able as research staff to try to help improve the integrity of the data that we were getting by being able to be present during survey administration and answer clarifying questions. So I think that was a help. And I think that is worth knowing that that's the nature in which it was administered. It wasn't done independently. And I think that would maybe raise issues as well in terms of the confidentiality of the information that people are reporting on. We might not want people independently completing some of these measures. And I'm sorry, I think I missed the PHQ-9 question.
Okay, let's see. Vera, if you don't mind typing it again, I accidentally deleted it. Sorry about that.
Oh, I see it here. Okay. Yeah, so the PHQ-9 tool we wanted to get so that we had a sense of depression symptom severity. We thought that might be something associated with other clinical outcomes that we were interested in this research. And it's a well-validated measure, so one that we could compare against. For instance, we used a lot of the new DSM-5 self-report measures, which are brief and meant to be used across a number of different clinical settings and research settings. So, you know, having a well-validated study to compare that against was useful as well. I believe the most frequent primary diagnosis was a mood disorders diagnosis. The diagnostic information I'm afraid to say I don't have readily at hand, but I think it was certainly depression and smaller numbers of psychotic disorders, bipolar affective disorder, and primary detox, so substance use disorder diagnoses, which would have made up about 35% in the substance use disorder diagnoses. Can I clarify further? I know that's a few questions.
Yes, of course.
Oh, I guess I meant, is there anything? Let's do one. I want to make sure I'm answering those fully.
Got it. No, she's her response is no, thank you. I'm so sorry. I'm not sure why you're not able to have your voice heard. I apologize for that.
Is it possible to get a copy of or locate the DSM-5 level 2? I mean, the form that you used, you said it was modified from the assist. Is it available?
It is. So yeah, so it's open access. It's available on the American Psychological Association's website, and all of the new DSM-5 measures are, you know, usable without charge, you know, and freely available online.
Are there different ones? Because I seem to see the one that asks about substance used in larger amounts or over a large period of time, and I'm not seeing where you've got the one that asks about the different substances.
Let's see. So I know that there is an adult and a child version of that survey. I don't know which survey you're looking at right now, but it sounds like it could be.
It was just the criteria, like a checklist, but is the level 2 substance use measure, what's the real name of the tool that you used?
So it's actually included right in the title of the article. So it's
okay. So,
yeah, the DSM-5.
Yeah, 5th edition level 2 substance use screener. Thank you. I stopped looking at the title after I started reading.
Oh, yeah. It's quite a mouthful, yeah.
It is a long title when you put it all together.
No, it would have been nice to have maybe a handy acronym.
Well, I appreciated the article like everybody else who's been speaking here, Matt. I enjoyed reading it. I liked your point that you set up in the very early article to point out the importance of it, that, you know, the ability for the nurses on the units to identify drug use in their settings is really important, and which brings back the point that you spoke about how your questions frequently can bring up other agents that people are using other than what appears on the drug screens. So I thought that was a really interesting point.
Thanks.
We are getting close to the end. So if anybody else has a question, Vera, your hand is always up in the sheet, and I don't know if you have other questions. And if anybody has any question, perhaps the best thing to do is to put it into the chat, since we were able to get Vera's. So I just want to let people know that we're 4 minutes away from closure. So if you have any other questions, please go ahead and submit them. In the interim, what is your plans for a follow-up to this study, Matt?
Yeah, so I think we're still in the early stages of thinking that through. I think a couple of things we'd like to do. Certainly, if we can integrate some of these measures into clinical care and see their utility when administering in that fashion, I think that would be a natural next step. And then we're also looking at on-unit intervention, and we're actually curious in particular about some mindfulness-based potential interventions that can be used on, say, a tablet or a device, something that wouldn't require, I think, a whole group and could be administered independently in people's own time on the units, and seeing what type of coping skills assistance we can maybe help to contribute to and show up in people's time in their hospitalization. So all in early development now, but we'll certainly be excited to do that. And we've also been looking at longitudinal outcomes in relation to some of the survey measures we've looked at. So seeing readmission and its correlates.
Oh, that's very interesting and very different from this article, it sounds like.
Yeah, I think we were able to hit on a range of ideas, and in particular within our lab, I'm the most, I think, substance use disorder focused, and so this was the area that I really wanted to take the lead on and explore further. But I think that's something that will definitely have people who I think are interested in carrying that forward.
Mindfulness would be something you could apply across the board, whether you're talking about your HIV studies or substance abuse. The idea of giving people ways to access mindfulness training while they're in the hospital sounds like a great idea.
Yeah, thanks.
Yeah.
Well, in these closing minutes, I also just want to say thank you all so much. I think the questions have been thought-provoking and helpful for us in figuring out where we want to go next. And I think great points are raised about its generalizability to some other clinical contexts, and I think some of the strengths and some of the shortcomings of the measure that we assessed. So I'm very appreciative of that. Thank you all.
Yeah, I think the more we can get to a place where we can apply it through all different settings, including for people like the ones I work with who have some legal implications, and people that Kathy works on who have some employment implications. And I think if we can show some good use in that setting, that would be great.
Yeah.
So thank you. Congratulations again on.
Yeah, this is quite a thrill. Yeah.
Yeah, it's pretty impressive to be the article chosen for the continuing education credit. So again, I invite everybody to, if they're interested in needing CEUs, to go online. You can do this through the Journal of Addiction Nursing website. And that's it. Thank you so much.
Great, thank you.
Appreciate it.
Okay, bye-bye, Matt. Bye, everybody.